All right, we are going to go ahead and get started. Welcome to our Reentry Advisory Committee meeting, and thank you all for joining. I'm just going to go over some housekeeping and agenda items and a short recap of our last advisory meeting. These are held every other month. So our agenda for today.
Yeah, okay, sorry.
Okay. Okay, so our agenda for today, again, I'm just going to go over some housekeeping items and a brief recap of our May meeting. We are going to discuss quite a bit today about ensuring continuity of pre and post-release care via case management services. We'll talk about overview of reentry case management, pre-release case management requirements, post-release case management requirements, and case management providers and models. And we'll discuss, we'll have a Q&A at the end and next steps. We also are having weather today, and so if we lose, if we cut out on Teams, Manat is our vendor that works with us and guides us and supports us in this reentry waiver, and they may have to take over, and then we will call in. So if just be prepared, some of us might be losing service. All right. So again, I just want to welcome everyone and thank you all for joining. Nevada Medicaid acknowledges that the successful implementation of the reentry demonstration will require flexibility and ongoing collaboration with state partners, correctional facilities, and community organizations. And to support this, Nevada is hosting this advisory committee meeting to inform policy and operational guidance for the demonstration waiver. This guidance will be shaped by current practice and capacity across correctional facilities and community organizations, and identify gaps and areas of concern for implementing partners. I just wanted to update everybody too that our waiver team, and mostly Michael Gordon, our federal waiver chief, and myself, and Bill Teal, who's a retired police captain from Las Vegas, are going out to every single carceral facility in the state of Nevada. So we are out there meeting, seeing the challenges that everyone faces, as well as the unique landscape of our state and how different each facility is. So I just wanted to thank everybody for being here and being flexible and working on this new implementation. I will be doing a few more slides, and then Amber Neff, our management analyst with the federal waiver team, will do some presentations, as well as Jonathan Figueroa, who is our social services program specialist, will also be presenting today. All right, next slide. We're just, again, using Teams. People are joining by phone and computer. Please keep your volume muted. We can automatically do it, but it looks like there was a few that came in that it didn't work on. If you could include your name and agency in the chat box, and if you also have a question, raising your hand or putting your question in the chat box. You can also, if you're on the phone, press 6 to unmute your line or *5 to raise your hand. All right, next slide, please. In the beginning, when I did the first introduction, you probably noticed that I said Nevada Health Authority. So as of July 1st, 2025, the Division of Healthcare Financing and Policy is now officially Nevada Medicaid. under the Nevada Health Authority. And I'm going to touch on real quick who comes under that now as well. Under the new organizational structure, I can still hear some talking.
Try to give them
All right, the following teams are housed under the Nevada Health Authority. And there's also a link at the bottom of the slide, and there's quite a few links throughout these slides that you can go to get additional information. Again, we were formerly the Division of Healthcare Financing and Policy. We are now Nevada Medicaid housed under the Nevada Health Authority. Medicaid eligibility policy from the Division of Welfare and Supportive Services is now the Division of Supportive Services. Patient Protection Commission, Public Employees Benefits Program, Silver State Health Insurance Exchange, Office of Analytics, Government's Council on Developmental Disabilities, Graduate Medical Education from the Governor's Office of Science, Innovation, and Technology, Waiver Provider Oversight from the Aging and Disability Services Division, and Healthcare Quality and Compliance from the Division of Public and Behavioral Health. So any with the asterisks were previously all or in part under the Nevada Department of Health and Human Services. Right. So when we met in May of 2025, I'm just going to go over briefly what we discussed. I'd also like to point out that, again, at the bottom of this slide, we have a Reentry webpage that's updated. So every meeting that we've had is on there. You can go back and watch these. All the information's on there. I highly recommend, even if you attended them, that you go do that, because there is a lot of information and it can be very confusing. So the advisory committee reviewed demonstration requirements for correctional facilities to screen individuals for Medicaid and pre-release service eligibility. Provide Medicaid application assistance, and provide information to Nevada Medicaid to suspend coverage during incarceration as appropriate. And a couple of the highlighted high-level areas of discussion that we talked about were Nevada Medicaid clarified that they are currently we have developed a new provider type 98 for correctional facilities to enroll as Medicaid providers under the reentry demonstration. In a future state, correctional facilities will be able to use the electronic verification system, some of you know it as EVES, to review patient eligibility information, including suspended status. Nevada Medicaid confirmed that most individuals enrolling in MCO upon release will be permitted to change their assignments once they are released from incarceration. If in individuals who are in a family unit, they will have a unique consideration that Nevada Medicaid will clarify future operational guidance so that the family's not on different plans. Nevada Medicaid will clarify expectations through future operational guidance for, and these were things that were brought up, individuals duly eligible for foster care services, privacy and security requirements for youth, and individuals who are transferred across correctional facilities, including jails. We also will be providing written feedback to a few of the questions that were raised in the main meeting. We have them ready to go, and they will be sent out this week. And I'm going to hand it off to Manette. I think Allison's on here.
Hi, thank you, Deidre. Can everyone hear me okay? Excellent. I actually think, Jonathan, we're turning it over to you, but I will just say hello. We're looking forward to doing a deeper dive today on our case management services. So without further ado, Jonathan, I will hand it along to you.
Great. Thanks, Allison. Hi, everyone, and good afternoon. Thanks for joining us once again. We're going to start off with key components of pre-release service delivery. Today, we'll be going over providing pre-release services during 90 days prior to release, which will include case management, supporting reentry planning, and providing a warm handoff as needed to post-release case manager and medications in hand. The next slide, please. So case management services and the reentry initiative. Case management is a core component of the reentry demonstration and critical to the successful transition of individuals reentering the community. The slide on your screen shows what those core objectives are, which are support the coordination of services delivered during the pre-release period and upon reentry, ensure warm handoffs, linkages, and referrals to post-release services and supports, and ensure the arrangement of appointments and timely access to appropriate care delivered in the community. Next slide, please. Pre-release to post-release case management. Individuals will receive 90 days pre-release case management services. Once released, that warm handoff will take place as needed, and they'll start receiving at least 30 days of post-release case management services. Next slide, please. Okay, case management services in the pre and post-release period. Case management services are focused on assessing and meeting an individual's health needs in the pre and post-release period, including behavioral health needs and other social service supports. There on your screen, you can see the pre-release case management services will consist of a health risk assessment, care plan, care linkages and coordination, along with a warm handoff. And then the post-release case management services will consist of navigation supports and following up with the individual to ensure continuity of care. Now I am going to hand it over to Amber to review the pre-release case management services.
Thank you, Jonathan. We're going to go over the services provided in pre-release case management. Our first one is the health risk assessment. You may hear of it as the HRA as well. Case management services must include a comprehensive assessment and a periodic reassessment of an individual's needs to determine the need for medical, educational, social, or other services, and to inform related care planning. Case managers must meet with individuals in person or via telehealth to ensure that an individual receives assessments of physical and mental health, substance use disorder, housing, and other social service supports and functional needs. So those of you who are in correctional facilities, we would appreciate you participating in a poll, which we're going to pop up right now.
It should be in the chat.
So
It will post in it.
okay, here we go.
Sorry, technical difficulty.
Try something. Okay.
I don't know why it's not popping up. Sorry.
Well, until we get the full polls figured out, I'm going to ask this question. Just think about your responses. We may ask you again for a response. It may come up. Oh, there it is. Is that it?
No.
No. Okay. So think about these requirements that I mentioned and let us know when we would love to hear from you in the chat. How well do the health risk assessment requirements align to your current practices? Do you feel that you're very close to this, or is there some things that you would need to work on? And then we will talk about the care plan.
It did go in the chat.
Oh, it's in the chat, you guys.
Sorry, this is our first.
This is our first time with polls. We're trying something new today. So in the chat, your poll. What are the choices?
Extremely well, somewhat well, and does not align with current practice.
Thank you. I'm going to move on to the care plan. The care plan is an actionable person-centered tool based on information collected through the HRA. And it engages the individual at the center of decision-making to support early identification and diagnosis of health conditions, facilitate connections to care, and improve health stability post-release. The care plan should include knowledge of the past and current health conditions, known providers, and other underlying needs such as vocational employment or housing. A creation of a care plan that identifies health goals, providing referrals, SUD support, and management of barriers. Correctional facilities, I have one more poll coming up here for you.
I already put it in.
It's in the chat. How well do the care plan requirements align to your current practices? Please respond. It'll stay in the chat. We're going to move on to care linkages, please. All right. Care linkages are the case managers will be expected to actively build a bridge between pre and post-release services in order to address identified needs and achieve goals specified in their care plan. Activities within this period include ensuring coordination and receipt of pre-release services, coordination with community-based and post-release providers, medications provided in hand upon release, information exchange and securing consents, and facilitating those warm handoffs. We have a question coming up in the chat. This one we would like you to respond in the chat. Let us know how the care linkage requirements align to your current practices. And this is primarily for our facilities. All right, I mentioned the warm handoffs. And within the warm handoffs, the care managers will be expected to conduct this warm handoff to post-release case manager if it's a different person, to ensure the continuity of care and access to services in the post-release period. A warm handoff should occur at least 14 days before release, but if it can't take place before release, it should occur within 1 week of release. The pre-release case manager will share reentry care plan and other pertinent information with the individual, the post-release case manager or managers, and any post-release providers. Conducting a pre-release warm handoff meeting, this could be in person or also in telehealth, builds the trusted relationship with post-release case manager and the individual. During the warm handoff, they will discuss the reentry care plan with the individual. They will gather consents for information sharing and identify other outstanding needs. That's the pre-release case management responsibilities.
We have another question that we're going to put in the chat.
Mhm.
If you could please respond in the chat to that.
Yeah, let us know how well the warm handoff requirements align to your current practices. Thank you. All right, we're going to move on back to Jonathan.
Okay, thank you, Amber. So post-release case management services. Post-release case managers must ensure supports are provided in the immediate post-release period and ensure the completion of the following post-release case management activities. They must ensure navigation supports and are ongoing and include referrals and linkages in the 30 days post-release, and also following up with individuals and monitoring in the 30 days post-release. Also note towards the bottom of the slide, as a best practice, post-release case managers should meet the individual at release. Nevada Medicaid is working to define additional requirements for post-release engagement and follow-up. Now I'm going to hand it over real quick over to Deidre to go over the question below.
Thank you, Jonathan. So the question I had here that we'd love to know more about, and feel free to raise your hand or put your answer in the chat. But to what extent are the MCOs or community-based organizations currently providing post-release services that meet these requirements? We've heard a little bit when we're out there, and we've seen a few MCOs out and about when we're visiting facilities, but we'd love to hear a little bit more about to what extent and are you meeting any of these requirements currently?
I guess I can go first. This is Regina. I'm a business change director overseeing the justice programs at Anthem Nevada Medicaid. I know all of the MCOs have dedicated justice liaisons, managers, and various programs. So Anthem is currently providing linkage and support and navigation for individuals post-incarceration. But one barrier that we face is we get these referrals ad hoc. So having data and information in advance would help us be able to serve more members. So I'll pause there.
Okay, thank you. Thank you, Regina. Do we have anybody else? I can't see the chat. I know I've got Bernadette and Richard are monitoring it. Russ? Okay, there's
We have
some
a
hands.
question from Russ. Russ, go ahead and take yourself off mute.
Thanks. Russ Alfano, Nevada Department of Corrections Medical Administrator. I was just wondering, you touched on the MCOs just now. Are there, and how many options or how many times are they able to adjust or change? Because I know some placements are MCO specific. They do or do not take certain coverages. And I'm just wondering if they go in pre-release and sign up with an MCO, but their placement that's been hard fought to get doesn't take that MCO, what options are then available?
So I'm gonna take a little stab at that question. So when they're working with a case manager and they're on an MCO and they're in that pre-release period, as they're getting ready to leave, and they know that they're going to a facility that doesn't take their MCO, they're still going to have to, they can switch their MCO when they come out, or right before they come out, so that they can get the services that they need. And that would be part of the support a case manager would be providing for them, is identifying what MCO would be best for them to meet their needs when they're in the community.
Can you hear me? Okay, just to build off of what Russ said and to kind of comment for Regina, here in our detention facility, first for Regina, we don't have a lot of time for the majority of our people getting released. We don't have a lot of time to set things up like that. A lot of times they'll go to court and get a release through the judge, or they'll post bail or things like that. So it's really hard to anticipate their release. But also building off of what Russ said for the MCOs, I've been finding with our MAP program, with the changes that Medicaid has had, and for the treatment partners that we've utilized, like Vitality in Carson City, New Frontier in Fallon, all the rural areas. If the individual is on an MCO when they come in, it is extremely difficult to change that for a court-ordered inpatient or residential treatment for Carson City or Fallon, because we can't change for fee-for-service and then vice versa. So we've been running into that the last 2 months here now. It's just really difficult to get them into places that have beds and things, because we can't change the MCO to fee for service and then back and forth. So I just wanted to kind of give you guys that input as well, what we're experiencing here.
Okay, that is really good information for us to have. I know
Bless you.
Where if people can mute their volume, I would appreciate it. We're aware of it, but we need to continue to be, aware of it and work on finding solutions, and even, hearing that and stories and everything. So that's why we're asking these questions today. So you guys just give us honest answers, and we're going to try to work on this with all of you.
I appreciate that. And just as a final addition to that, I know like Vitality and a couple of other places were working hard with us, Carson City Counseling, CCC. They were trying to do pre-auths
for the MCOs. And I know that we were able to kind of find a little bit of a solution with that. It just depends on which MCO they have. So that's the other challenge, is certain ones are either not doing the pre-auths or just not responding. Now, I don't have the specific ones that we've been having trouble with. I can ask my partner tomorrow and email you that information of who we're kind of not seeing those pre-auths come through. But it's just, again, it's a challenge lately for us. But I appreciate you guys. Thank you.
Yeah, thank you. Yes, Maggie, if you could send us that information, that'd be great.
Absolutely.
And Richard is I think Richard and Bernadette are monitoring the, okay.
Yes.
So
And go ahead, Regina, you have a question?
Sure. So I'd like to go back to a couple of slides, but this is on the same line with what Russ was talking about. So I think slide 5, we're talking about offenders that are suspended. So they have an MCO assignment right before they're incarcerated, and then they're suspended Medicaid status, right? That's the variable that gets really tricky as we're seeing trying to plan releases, right? Because they can sign up for Medicaid if they're new to Medicaid and pick any MCO of their choice. But the ones that are suspended, the guidance that we've received is that they're staying on that plan, right? That's the plan that they're going to have upon release. But then I want to talk through this maybe further, and I think my counterparts at the other MCOs would like some guidance as well. You know, we have inmates who are asking to switch to another health plan. Maybe their family is on that health plan. Maybe it's the most appropriate plan based on their parole officer's recommendation, right? So there's a form we've been provided from the health authority for the good cause disenrollment form that some offenders can submit prior to release, but there's no guarantee that they would get that switch. So I guess maybe something we can talk through as a group, what is the most appropriate way we can serve the suspended folks that are assigned to one MCO but want to switch, or they have a plan that has specific needs. So I'll pause there.
thank you, Regina. I can answer a little bit of that, but I think what this is part of why we're doing this too, is so that we can have some further discussions, even just with maybe the MCOs or, with us as we're getting closer to implementing this. But if, say, for example, they are suspended and their family is on an MCO, we are working on a way that they can be on that MCO, the same one that their family had, like if it's a mom and her children, something like that, or if they need to be on a different one to meet their needs. So that is something that we are working on and aware of. As far as the rest of your question goes, I think that is going to be a very good discussion, and we don't have enough time to do it in here, but we are definitely coming back to that. So Manat is here on the call as well, and we're tracking all this, so we will definitely do that. I appreciate your questions, Regina. You have great questions, so thank you.
And Henna, go ahead.
Yeah, so good evening, everybody. Henna Zaidi with Advantage Healthcare Services. I just wanted to respond to the question that was presented on the slide regarding what extent our post-release services provided. So Advantage is, we have a unique model. We're a specialty behavioral health pharmacy that operates in Nevada and in California, and we also provide case management services. So we actually provide medications to individuals upon discharge from the jail system. And then we assign a community health worker. So we have a community health worker model to provide the post-release services that are generally around care navigation, getting connected to the next site of care, scheduling follow-up appointments, but also ensuring that the individual has access to their medication and they they have education on the medication that they need to take, etc. So we do all of this. The catch is that we are able to provide these services through grant dollars. We are not contracted with the MCOs, and we would like to be contracted with MCOs for these services. But currently, a lot of the services we provide is just through grant dollars and other braided funding that we can leverage on the back end.
Thank you. That's great information. If you can maybe put your information in the chat as well, your contact information, agency name, that would be great. And I'm assuming, I think I heard you say that you are doing this in California, which they were the first state to get the reentry waiver approved. So
yeah, we have this program live for CDCR, which is essentially the prison, the state prison system, and we support their behavioral health reintegration programs, where we provide the discharge meds plus the case management through a community health worker model. And then we are having active conversations with other jail systems. As you mentioned, California is a little further along in implementation of their CalAIM waiver. So the jails have just started releasing RFPs around getting connected to post-release services. So that's a lot of the work that we're doing in California.
All right. Thank you, Zadie. Zadie.
Hannah Zadie.
Hannah. Okay, sorry.
Yes. That's okay. That's okay.
And then Deidre, we have one more question comment in the chat. This is from Lance Mesker. These can be much different in short-term juvenile detention settings that I currently work in. I am hopeful more information will be shared on these settings.
So we do have we are doing a lot of work with the juveniles, and I don't want to get too far into it, but these reentry meetings that we're having right now they're really designed around the waiver. So right now the CAA and the youth are we have that is going, but once our waiver goes through, this waiver will take over all that and expand the services to the youth that we follow, that we serve. So yeah, if you go back on some of our past meetings, you might find some other information on there, on the slides, what that looks like, but you are also can email us, and we're happy to, reach out and talk to you about it. If your agency needs us to come share information, something like that, we can definitely do that. So if you can just put your information in the chat, that'd be great.
I also added our email address in the chat.
And I'd like to ask the MCOs and the community-based organizations if I think Regina mentioned that most of the MCOs have a liaison for the carceral facilities. If you are on this call, or your coworker that is not on the call, but you have their contact information, if you could put that in the chat so we can reach out to you, that would be amazing. And I am going to turn this over. Thank you guys. That was great information. This is what we need to do. You're up, Jonathan.
Thank you. All right. Yeah. Next slide. Pre-release case management providers. So Nevada will utilize embedded and in-reach case managers during the pre-release period. Embedded case managers who work in correctional facilities, either as employees or contractors, will provide pre-release case management services to the incarcerated individuals. The in-reach case managers, they will utilize community-based organizations or managed care organizations working in partnership with correctional facilities, either in person or via telehealth. Next slide, please. Pre-release case management models to allow for flexibility, implementation and maximize continuity of case management and access to services in the pre and post-release period. Correctional facilities may choose their preferred pre-release case management model, either embedded or in reach, as shown on this slide right here. Next slide, please. The post-release case management providers. So Nevada will leverage MCOs and community-based providers to provide case management in the post-release period. So for those enrolled in MCOs, the MCO will deliver post-release case management. And then for those enrolled in fee-for-service, the community-based providers will deliver the post-release case management. And then also note on the same slide at the bottom, individuals who are released mid-month while their managed care enrollment is pending may require case management services from a community-based provider in the immediate post-release period and a warm handoff to the MCO case manager once assigned. Now I will hand it back to Deidre, who will speak on individuals with long stays.
Thank you, Jonathan. I just wanted to point out on this one that we are working to define requirements for individuals with short-term stays or unknown release dates. We have heard this from every facility we've been to, and we do understand it now and what that looks like. So we are working on that, but continuing to get feedback and information, and even when this is up and running as a demonstration, there will probably be a lot of kinks in this, and so we're going to have to, as other states have said, we have to be flexible and pivot, and what works and what doesn't. So that is definitely something we are aware of. So what I'm going to do is just walk you through this real quick of what case management would look like for an individual with a long-term stay. So at intake or 120 days pre-release, the facility screens for Medicaid enrollment and pre-release services eligibility. So that's, again, that 120 days pre-released or at intake. And then number 2 is the facility identifies a pre-release case manager. So we talked about Provider 98, and that is basically an umbrella for the facility to continue to work with the providers they already have, bring in additional ones, change them, that sort of thing, because we realize each facility is very different, and the populations and where they're located. And then you move on to number 3. So the next step would be the service provisions throughout the 90-day pre-release period. So the pre-release case manager, which may also be the post-release, ideally that would be wonderful. It conducts an initial contact, completes a comprehensive assessment, and develops a care plan with the person. The facility or in-reach provider provide additional pre-release services. Then we go back up to number 4. So if applicable, I can't say that today, I'm talking too much, conduct a warm handoff to the post-release case manager. So that's why I said it would be perfect if this could be the same case manager, support of a community health worker, which we're having there as well. And then number 5, the facility or in-reach provider, as needed, provide 30 days of the prescription medication. So that's day 1 at release. That's how that would start. And then on to step 6, the 30 days post-release. Ongoing services throughout post-release period would include ongoing navigation supports and continuing with follow-up with the individual to ensure receipt of services, and engagement with community-based providers is meeting the needs for that individual. So you've got the 120 intake or 120 days, then at the 90 days, what is to be taking place, and then day 1, again, that 30-day medications in hand, and then the post-release.
Hey, Deidre, we have a
Yes.
few questions in the chat.
Okay.
The first one is from Jessica Johnson with CareSource. We are new to managed care in Nevada and look forward to beginning membership in the new year. We are actively hiring for a justice liaison. Once hired, who should we connect to?
Minden is putting in the our email address in the chat right now.
Okay.
Thank you. Nice to meet you.
Great to meet you as well.
We have
All right.
another.
Yes, we do. This is from Leah. Post-release recipients receive targeted case management through the current PT Provider Type 54 probation targeted group. This is an MCO carve-out service. Are we saying this is going away?
Leah, I could not answer that, but yeah, that's not, I can't answer that. I don't know if Michael is on the call and could answer that, or if Sarah Dearborn's on the call.
I'm sorry, what was that question?
The question was from Leah asking if provider type 54 for targeted case management post-release would be going away for carceral youth post.
Yeah, so that'll transfer over to that PT 98 that we had already talked about.
Yes. Did that
Go
answer?
ahead. Go ahead,
the
Leah.
question?
Your hand's up.
Hi, yes, this is Leah Lamborn. So the reentry, I understand you're creating a new 98 for the early periodic services, screening services, and then the case management pre-release. But what happens is once the child is released, re-enters back into the community, they are normally put on probation, then they fall into the normal provider type 54 for the targeted probation group. So
Yes.
there
Yeah,
haven't been, and so my question is, I mean, this group still continues, right? This reentry program isn't going to dissolve the probation targeted group case management services that probation officers are providing currently to this population.
Correct, but they can't both be claimed at the same time. So there might be that 30-day period of post-release that has to follow under the PT 98. And then continuation of anything after that would have to fall back to the PT 54.
Okay, because our systems aren't designed to track currently who's been released 30 days, who would be billed under a 98 versus a 54. And then if you're saying a 98 post-release is going to be provided by a managed care organization, that's our concern. I mean, because it's going to be a probation officer.
Right. So it doesn't necessarily, so for juveniles, it doesn't necessarily mean it'll be under an MCO. It could still be under fee for service. So we're still working on all those operational details on how that's going to look. And then that's, again, part of these discussions on how we're going to be able to make this work on both ends.
Okay. And then, so when is the PT 98 effective? When will that be up and going?
It should be effective late fall.
Okay. Thank you.
Thank you.
Okay, we have an additional one from Regina. Do we have anticipated volume for the number of offenders who may be in need of post-release case management services from the MCOs in this program?
I'm going to, I believe, Allison, I believe we have, I mean, I know we have had that information because that's part of writing all this and grants and everything, but I don't know if Manette could answer that.
Yeah, I think we'd want to take it back. We did include some estimates in the waiver application showing what projected enrollment would be over the 5 years of the course of the demonstration. As you might imagine, we anticipate that it will grow over time, both as facilities start coming online and start really building the infrastructure that will be necessary for the program. So we do have those numbers. We can get that back to you. I don't have them handy, but we have started thinking about that as well. And then I think we'll obviously want to hear from correctional facility partners and MCOs. There'll be this anticipation that working together in partnership to really be able to get a handle on who will be eligible for the services. So that's my way of saying I think that they'll be refined, but there are some early estimates that were included in the waiver application, and we can make that information available coming out of the call.
Thank you so much. I think you get from our standpoint, we want to plan, right? We want to plan for
Absolutely.
what's going to happen. So thank you.
Yep.
Absolutely. All right. Good discussions and great questions. Thank you.
That was all in the chat for now.
Thank you, Richard. Yes, go ahead. You're right.
All right, we're going to open the chat for any questions. We're going to continue with our Q&A, nothing specific, anything that we talked about this afternoon. Bernadette is on the computer also, and she's capturing these questions during this conversation. So if there's anything, if you'd like to raise your hand or if you'd like to type your question, we can go all the way back to what we talked about all through this meeting, or just kind of catch up, see what you have thoughts of.
Yeah, you might have some questions if you haven't been to some of these meetings that we can even address in a written follow-up, anything like that.
We've addressed them all.
I know we will be doing something as we're ramping up to that we'll have like by probably two times a month where we'll just be available for phone calls for people to call in, talk, ask questions, whatever. That should be, we'll probably be starting now, thinking like August, September. We're getting questions? Okay.
We do have a hand up from Gabrielle Stone. Go ahead.
Thank you. Yeah, my name is Gabby Stone. I'm with Churchill County Social Services. Part of what I do is our FAST program working with the inmates at our county jail. One of the issues that I'm seeing now that some of the treatment centers are requiring pre-authorizations is getting people on Medicaid while they're in the jail. So we have some that are just kind of ended up stuck. So I'm wondering about the 1115 waivers. Are those something that can be submitted now, or do I need to wait? If I could just get some more information around that.
Yeah, and again, I would encourage you to go to our website. We keep everything really up to date on there. So the waiver, this 1115 waiver has not started yet. It'll be starting here in a few months. We do have an application for incarcerated individuals. It's a shortened form, and it is just for individuals that are incarcerated. That is already on our website. And so when the waiver, if we're just waiting on Medicaid right now, we're there. We're just waiting for the for the go. And we're staying on track, putting all this together. So that's kind of where we are with that, but I would go to the website and look, you can get current information. The application's on there as well, and you can see the short application. And when it gets returned, it goes specifically to people that know that these are incarcerated individuals. And that form can be used for any eligible youth, which includes up to the age of 26 if they aged out of foster care. It can be used for them now under the CAA.
Okay, and we have another question from Leah Orozco. Go ahead, Leah.
Hi, Leah Roscoe with Anthem Medicaid. I'm the Justice Liaison. Just a quick question. I know that we do have offenders that are signing up with an MCO prior to release. We established that, and that they can change 30 days after. Do you know if anyone is providing them with the information to do so? We see a lot of offenders who come out and they're kind of in limbo. They don't know how to do that yet. So they can't get into treatment or housing. I was wondering if that's a plan.
As we're designing all this, yes, and we also are going to have community health workers that can be part of this, and hopefully that's something that they can really provide that as well, helping them with that. But
Great.
I'm glad you brought that up because it's very important, and we see that when we're out there too. So. Yeah.
Yes, ma'am. Thank you.
Thank you. More? Right. Good questions. Oh, Kevin.
Oh, I was debating about asking this question. Kevin Murray, Silver Summit. I'm a manager of housing and justice involved systems. I know there's a lot of questions, especially about prior authorization and services. I just wanted to confirm that medical necessity is still required for the levels of care. So they do have to meet the level of care criteria if they are exiting a carceral facility, and they are court ordered to care, but may not meet that medical necessity criteria. I just want to make sure that the court order doesn't supersede medical necessity, or is there any future alignment on some of the services? I know there's varied kind of knowledge in this space, so just wanted to ask for some clarity there.
I could not answer that, Kevin. Mike.
Allie, do you want to take that?
Michael, I think we would want to take that one back as well. I know that this prior authorization and some of these questions have come up a number of times. I was going to say for Gabrielle as well. It looks like Sarah has her hand up, so she might be able to weigh in on it. But I just want to acknowledge that we received some of those by email as well. And so I know everyone is focused on providing clarity on the prior authorization and related requirements. But Sarah, I see that you have your hand up. I don't know if you wanted to weigh in on that piece.
Can you hear me okay?
Yes.
Yes.
Oh, okay. Sorry. I'm working on my phone and it's not working great. But thank you so much, Allison. I think what you said was perfect. We can definitely take that back. But traditionally, all Medicaid services require individuals to meet medical necessity regardless of the court order. So that will be something we can work through. But again, taking it back and can follow up. Thank you.
Thank you, Sarah. It looks like Brandon has his hand up.
Hi, guys. Yeah, I was just commenting on the PT98, and I think that kind of ties into some of the prior authorization as well, because now we'll have a provider type, right, where we'll be getting prior authorization for the services, trying to provide medical necessity or medical justification. I'm thinking this probably also helps with the staffing issue, right? So then we'll have case managers, potentially CHW workers. I'm guessing that maybe linking to this provider type 98 and they would be the ones that could provide some of these services. So we're not putting all that burden on the facility staff. Is that how it's kind of looking?
So,
I'm just trying to picture it in my head a little bit as we're talking.
Yeah, so provider type 98 is for carceral facilities. It's for the so it was designed, I'll give you an example. You have a prison and they have, no, not a prison, a jail. You're in rural Nevada, you've got a jail, and they have a nurse that comes in every other day that lives there in the community, and they pay her. And then they have NAF care who maybe is doing all their medication and some other things, and they're paying them. The jails are paying them. There might be a doctor, psych doctor that comes in once a week from that community, and they're paying them, and they have a pharmacy in their community and they're paying them. We want them to be able to keep those same providers. And so the carceral facility will be the provider. They will bill Medicaid, they will bill us directly, they will get reimbursed, and they will pay the people that they're using. Will the pay be the amount that they're paying them? No, but it'll be at least 50% of that, and it's better than what is happening now. They're all just paying this out of pocket. We know that HIV medication, the psych medication, all the different things that some of these jails are paying out of their budget, and it's it's wiping them out. So that we made it easier so that each facility could continue to be have that individualized, using the providers that best serve them in their community. So
okay, I like the idea. I think that's great. I think it solves a lot of the issues. We can go and we can help them credential and get their providers enrolled with Nevada Medicaid. Hopefully they meet the qualifications and all that. And, I'm guessing the prior authorization process would probably start through there, for some of the services. I'm hoping not everything needs prior authorization, maybe like, the initial stuff, but I don't know. I'll be interested in seeing how that develops.
Thank you. All right.
Okay, we have another question from Russ.
Yes.
Good morning. Apologize for the sneezing earlier. That was me.
That's okay.
Anyway, it cued me to shut off my mic. How does that work? Coming off, just tagging off of just the conversation you had with the up to 50% reimbursement. How does that work if you're an internal, like the Department of Corrections? We have our own pharmacists. By and large, they're seeing our providers, but we're already paying. Do we have the option of 90 days prior to release, us being able to assign the medication we're giving them through NDOC? Are we going to be reimbursed for that piece? Is that?
Yeah, I'm going to have Michael answer that, but the carceral facilities, the prisons, the state prisons are you guys are not number one, but yes, and Michael can probably explain that a little bit better.
So yes, so some of the medications are going to be reimbursable. And because pharmacy is a point of sale, we're definitely already raised that question on how we're going to work out the details with your internal pharmacy for them to become a Medicaid provider and be able to bill point of sale. So those details are still in the works. And I know we're meeting with your administration at the end of this week to talk about possibilities and how we can work some of that out.
Thank you very much. And just a follow-up, if I may, and then I'll shut off my mic even because I feel sneezes coming on. Does the by enrolling or becoming the NDOC Central Pharmacy, by that becoming Medicaid enrolled, does that then extend to like 340B pricing or the other components that are inherent in Medicaid pricing?
That I cannot answer. That we're going to have to leave up to our pharmacy team, because that's above my knowledge level.
Thank you.
Thank you, Russ.
But please submit that, Russ, to us, so we can get clarification on that.
Okay.
Yeah, if you could email it or put it in the chat, that would be great.
I'm going to chat right now.
Looks like Kevin's got his hand up.
God darn it, he asked such a great question. But will NDOC be affected with the singular PDL list that's coming online? And will they then, if they enroll, have to kind of pivot to align with those moving pieces as well?
That is another question we've already raised internally, and we do not have an answer for that. So we are definitely looking at how we're going to be able to work through that.
All right. Great discussions and questions. I really appreciate it. This is what we've got to do, and this helps us as we're preparing for our next meeting with everybody, and as well as when we're working on the designs and scheduling, even putting some other meetings that we don't have on here to continue this work. So our next meeting is going to be September 23rd, and we'll be talking more about providing medications, including medication assisted treatment. And then November 18th, providing other covered services. And we have this out until January 26th of 2026. And we'll see where we're at then, as we've started to do some implementation and some of the facilities that will have gone live by then. So keep those dates on your calendars. We really need you all here. Good. I think we're done. I appreciate it again, all the discussion. Very helpful. Thank you. Bye. Thank you.
Thank you, everyone.
Thank you.
Thank you.
Thank you.